Ladies and gentlemen, I warmly welcome you back for the Symposium 4 of the annual academic sessions of the College of Pulmonologists. The theme for this session will be regarding oncology. And for that, we have two distinguished dignitaries. We have Dr. N. Jayakumaran, consultant oncologist at the Apeksha Hospital, Maharagama. And we have Dr. Damit Rodrigo, who is a consultant respiratory physician at the District General Hospital at Hambantota. Sir, the floor is yours.
Okay, we welcome you all for the Symposium number 4 on oncology. And to chair this session, I have with me Dr. N. Jayakumaran, consultant oncologist from Apeksha Hospital, Maharagama. So we'll start with the first lecture. I would like to introduce Dr. Ramani Punchiheva, consultant pathologist from National Hospital for Respiratory Diseases, Valisara, to deliver the first lecture on what is new in lung cancer diagnostics, a pathologist's perspective.
Good morning. Let me thank, first of all, President and the Council of Sri Lanka College of Pulmonologists for giving me opportunity to deliver this lecture. Right. What is new in lung cancer diagnostics, a pathologist's perspective. So, right, I will cover this during this 20 minutes introduction, correct terminology and classification of lung cancers, diagnostic techniques, and the summary. Right. Before we discuss about the lung cancer is the most common cause of cancer in worldwide, with more than 2 million new cases and 1.7 million deaths estimated globally in 2018. In Sri Lanka, according to the National Cancer Control data, in 2019, lung cancer is the second commonest malignancy in male. Right. This pie chart appreciates the values of this and the 10 commonest malignancies in males and females separately. The first pie charts illustrate the female figures in 2019 data. The commonest malignancy is the breast, but the lung cancer is within the first 10 malignancies. So that means there is the importance of the lung cancer in females as well. But in the second pie chart that illustrates the male predominant malignancies. The first malignancy is the lip, tongue and oral cancers. And the second commonest one is the lung cancer. That means we have to think about the lung malignancies more thoroughly. Right, these charts will show some the trends of age-specific incidence rates of lung cancer in females and males. Males will be the blue line, and the red line will be the female figures. Right, compare with the world figures. These Sri Lankan figures will be for the female 3.4, but in compare with the male, this age-specific incidence rates in Sri Lanka higher. Compare with this the Asian, Southeast Asian figures, very more or less same. So this we have to think about the vigorous the screening and diagnostic techniques for this lung cancer diagnosis. And this figures wise, in number of new cases they have detected during the 2019, 457 for the females, as well as 1,264 cases for the male. So having said these things, and think about this, the normal these lung diagnostic modalities. During the past 15 years, the world has witnessed accelerating advances in the treatment of lung cancer patients. translating into the significant improvement in their survival. These improvements, they are largely due to the advances in the new knowledge of molecular aberrations occurring in the disease, as well as technical advances in how we integrate these aberrations and development of the therapeutics in overcome these. But nevertheless, histological classification of the tumors remain the backbone of lung cancer diagnosis and patient management. Therefore, the pathologist role is very essential. And MDT approach mandatory in lung cancer management, especially before as well as the after the biopsies. So before also you have to discuss the relevant cases at the MDT and get the fullest, the maximum input from the clinicians, radiologists and other oncologists. And after the biopsies as well, you need to have a good this discussion at the MDT with regard to the histological types. So before that, we need to give a the correct terminology and classification. This is our duty, actual pathologist role, to give the correct terminology and the classification. Usually we use the latest WHO categorization. Now the latest one is the 5th edition. That one, the edition was issued in the 2022. So, but at Velisara, usually we use this WHO latest classification. So, what are these classifications? There are two classifications. One is the small biopsy cytology specimen, and other one for the resected specimen classification. And when we were trainees, actually when I was a trainee, we used only one single classification. We use only whether it is a small cell carcinoma or a non-small cell carcinoma. We didn't go beyond that. We didn't give a bottom line diagnosis because of the availability of this specialized treatment. Because nowadays we can't stop that point because of this availability of targeted therapy, especially this personalized medicine. So we need to give whether it is a squamous, whether it is an adeno, whether it is a neuroendocrine tumor, especially the small cell carcinoma. So that's because of this reason, they have divided this small biopsy and cytology together, one classification, and the resected specimen classification separately. So this small biopsy cytology specimens, actually the clinicians, especially these pulmonologists, chest physicians, you all are the initial the assessor for this specimen. So the 70% of lung cancer patients are advanced stage, so unresectable stage, and diagnosis must be based on primarily on small biopsy and cytology specimen. Therefore, the precise histological classification with molecular testing is essential for systemic therapies. So this classification is based on special stains, especially the mucin stain and the immunohistochemistry. At Velisara, National Hospital for Respiratory Diseases, Velisara, we have these facilities, mucin as well as the immunohistochemistry. We give a complete diagnosis on small biopsy as well as cytology. The other thing, these tissue samples are not only for the diagnosis but also for the therapeutic purposes, especially this molecular testing. So therefore, we need to preserve tissue as much as possible for a molecular testing. So we don't do unnecessary trimming. We have used some technical guidelines for the MLTs to how to handle this specimen. So to avoid unnecessary wastage. So this then the resected specimen classification. Once you diagnose the lung malignancies on small biopsy, we can put into the multidisciplinary meeting. Then after the staging, if that stage is low, is it a resectable stage? Then we can refer to the thoracic surgeon for the resection. And after the resection, we use the different category classification for but same way but modified ones for the classification. Especially certain tumors you cannot diagnose on small biopsy, you have to examine the entire lesion. Examples, adenocarcinoma in situ, minimally invasive adenocarcinoma, large cell carcinoma, large cell neuroendocrine carcinoma, carcinosarcomas, mucoepidermoid carcinoma, and adenosquamous-like tumors you cannot diagnose on a small biopsy. You need to have examine the entire lesion. Especially you need to have a resected specimen. So, but resected specimen need to give the subclassification. Example, if it is an adenocarcinoma, there are 5 types of subclassification in the WHO. They are according to the predominant part, whether it is a acinotype, whether it is a papillary, whether it is a micropapillary, whether it is a lipidic predominant or a solid type. So if you diagnose on the adenocarcinoma on the resected specimen, if it is a predominant part is a solid, then the adenocarcinoma solid pattern. But always we have to do the lung primary marker, especially TTF1 or a NAPCNA, to confirm this is a primary lung, because certain patterns are the overlap with the metastatic disease also. Then after this the subtyping, you have to give a pathological staging according to the 8 TNM classification, and you have to give the grading of the tumor and the status of the resection, especially whether it is a resection margin, bronchial resection margin, or a staple resection margin, positive or the pre, you have to give. And the other thing, additional pathological prognostic features like vascular emboli, necrosis, or a perineural invasion, those additional features you have to mention. Right. So, some little the elaborating of this the small biopsy interpretation. The first category, if you what are those small biopsies? Bronchial biopsy, true cut biopsies, cell blocks, transbronchial lung biopsies, etc. Right? So whenever you get these biopsies, we have to assess whether it is a malignant. If it is a malignant, carcinoma is the commonest one. And if it is a carcinoma, whether it is a small cell or a non-small cell. If it is a non-small cell, the features favor adeno. If you have a clear features of adeno, especially glands, acini, papillae, lipidic growth, or a micropapillary pattern, no doubt it is a adenocarcinoma with predominant. Compare with the fourth edition, you don't have to give the pattern. Earlier we used this only the non-small cell carcinoma favoring adenocarcinoma. But in this fifth edition, you have to give the predominant growth pattern. Why? Because your certain growth patterns give some clues for the molecular selection as well as the prognosis. So example, if you have a lipidic or a papillary growth pattern, it has a very good prognosis, right? And the higher chance of positivity with the EGFR. So if you see a tissue, the pathology report like small biopsy with the adenocarcinoma, lipidic growth pattern, there is no doubt it is a high chance of being positivity with the EGFR. So you can go ahead with if it is a metastatic state. So then if it is a solid or a micropapillary growth pattern, your prognosis wise it is poor compared with the lipidic and other papillary growth patterns. And the other thing, solid and signating type of cells are there. ALK positivity is higher compared with the other ones. So one thing I want to add this one, if you have a very good rich small lymphocytes in the background of tumor, especially in this the solid pattern or a micropapillary or papillae, so it is an advanced stage lung cancer. The tumor stroma is very rich with their lymphocytes. That is a very good candidate for a PD-L1 and the PD-1 immunotherapy. Usually in my reports, in our reports, we mention host reaction in the resected specimen because it is an advantage to select the PD-1 and the PD-L1. So the next category, if you have a clear evidence of squamous cell carcinoma, that means keratin pus, intracytoplasmic keratin, intercellular bridges, no doubt it is a squamous cell carcinoma. Usually, I don't do the immunosuppressed squamous because no point wasting of our immunos in our this economic crisis. So we don't use these markers to confirm the squamous. But for the adeno, we use because we want to separate whether it is a primary or a secondary. So then the third category, non-small cell carcinoma, but with no clear adeno features, then you have to do a immunomarkers, either TTF1 for a glandular adenopart and P40 for the squamous. Usually in our hospital, we use this P63 instead of P40, but P40 is superior than the P63 for this squamous cell carcinoma. If this P40, the TTF1 is positive, then we can say non-small cell carcinoma suggestive of adenocarcinoma. The same way, if you don't have any clear features of the squamous or adeno, but P40 is positive, you can say non-small cell carcinoma suggestive of squamous cell carcinoma. And in small biopsies, whenever you do the limited panel of immunohistochemistry, especially TTF1, P40, the both were negative. If it is both negative, then you can't say whether it is an adenosquamous. Then you can stop that as a non-small cell carcinoma NOAs. Because of limited the tissues and the immunohistochemistry, you can stop at this point. But in a very good setting, you have to reduce this NOS category as much as possible. And the other thing, this is for the small cell carcinomas. If you have clear features of small cell carcinoma, ideally we do 2 immunomarkers for the confirmation as a neuroendocrine. Usually the chromogranin, synaptopycin or a CD56, either 2 out of these 3. So the morphologically, small cell carcinoma is a very well the clear feature, because ideally I don't have to do the any immunos for a small cell carcinoma, because some people they are asked for the immunos. That's why we do the immunos for a small cell carcinoma routinely. Otherwise, we don't want to do the immunos for the small cell carcinoma. And other thing, this 7th category is the neuroendocrine carcinoma features. There are certain features to favor neuroendocrine. That means they are very bland looking cells. Stipple chromatin, cytoplasm is very eosinophilic. So that may be a neuroendocrine feature, but not like this small cell. So in that situation, most likely a carcinoid. But in that type of carcinoid cases, we usually do the 2 out of that 3 immunomarkers plus Ki67. That is Ki67 mean proliferation index, because it is very useful to differentiate whether it is a atypical or typical carcinoid. So this is a summary of this small biopsy versus this resected specimen. Usually if you have a clear evidence of glandular pattern, squamous pattern, squamous cell carcinoma, resected specimen also squamous cell carcinoma. But in the resected specimen, squamous cell carcinoma, there are 4 categories, whether it is a keratinizing type, non-keratinizing type, basaloid or a lymphoepithelioma-like patterns. But in the clear evidence of adeno, you have to give the list the patterns. But there are 5 categories, as I described earlier, these WHO categories. And if you don't have any clear evidence, you have to do the immunos and compare with the immunos and give the relevant diagnosis. Then the diagnostic techniques. So, diagnostic techniques in lung cancers, histology is the gold standard. H&E diagnosis is the gold standard. Once you diagnose on the H&E, you can do the special strains like mucin to elicit the adeno, because glandular epithelial cells contain mucin, Alcian blue. Usually we do the Alcian blue. But problem is some squamous cell carcinoma also give the positivity with the mucin. So usually I don't use this mucin stain because this immunohistochemistry is far superior than the mucin stain. So then the immunohistochemistry. As I said earlier, TTF1, nepsinin for the adenocarcinoma lung primary, P40 and the P60 for the squamous differentiation, and CD56 chromogranin synaptophysin neuroendocrine tumors, small cell carcinoma, and the carcinoid tumor. For the carcinoid tumors, you have to use the Ki67 other than these neuroendocrine markers. Then the cytokeratin. Some people, they ask about the cytokeratin. Ideally, we don't use any cytokeratin to diagnose lung cancer on a small biopsy because to avoid the unnecessary wastage. And if you are sure about this carcinoma, there are features to say carcinoma. So if you are doubt about the carcinoma, if sometimes you can have the single cells, whether it is a lymphoma, whether it is a something else like a melanoma or some sarcoma. In that type of situation, we can use the keratin. Otherwise, we don't use this cytokeratin. But in certain cases like metastatic disease, if a patient is known case of breast carcinoma, if the patient is known case of renal cell carcinoma, if the patient is known case of colorectal presence with the endobronchial lesion, so that type of situation we can use the cytokeratin to rule out the metastasis. So in cytokeratin 7 commonly used for the ovary, breast, lung. And CK56 usually we use for a squamous origin, and PCK means pancytokeratin. Any doubt about whether it is a lymphoma or carcinoma, we can use this PCK. And the CK19 usually we use to rule out any possibility of pancreatic or biliary cases. And the CK20 is a marker for the colonic GIT. So whenever you have a history of colonic cancer, we can use this thing. Then the next, the most important one is the molecular testing. But molecular testing, as a routinely we don't use at our center because we don't have that facility. But in the developed countries, they straight away use this molecular testing once they diagnose the lung adenocarcinomas. So commonly they used in advanced lung cancers. Especially for the metastatic disease, the common panels are EGFR, KRAS, BRAF, ROS1. These can be used. This can be done by using either PCR technique or a next generation sequencing. So for the ALK rearrangement, usually we don't go straight away for the molecular testing. First we'll do with the ALK IHC. There is ALK immunohistochemistry. If the ALK IHC is positive, then you can go ahead with the ALK rearrangement. So the other one for the immunotherapy, PD1 and PDL1 we can use. This is a IHC markers. And summary, the MDT approach to lung cancer disease is a standard of care. Pathologists are key members of the MDT and should be consistent with regular contributors to the lung cancer MDT. Always use correct terminology and classification according to the new WHO, especially 5th edition, for a better understanding. And give the correct diagnosis after special stains and IHC, immunohistochemistry. Preserve the tissue as much as possible for further molecular testing. Thank you. It is the end.
Thank you, Dr. Ramani Punjiheva, for the very excellent and very comprehensive talk on the newer development in the pathological aspects for the lung cancer diagnosis. As you correctly said earlier, when we were also registrars, we wanted only the whether non-small cell lung cancer or small cell lung cancer, and we relied on only chemotherapy. But with a lot of advancement in this pathological information, further refined information, plus advancement in radiology radiotherapy techniques and advancement in surgical techniques, we are now in a better position for managing this lung cancer. So the next topic is lung cancer management. What are the choices? So many choices are there, in what sequence and how we are going to manage in an excellent way as a precision medicine. There are two eminent speakers are here. You all know those speakers very well. First one is Dr. Nurad Joseph. He is a very eminent consultant clinical oncologist. He is holding international recognition as well, and he has written many chapters in oncology, and we are very proud of him being our oncologist in Sri Lanka. And he is currently working as a consultant oncologist at District General Hospital, Hambantota. And second speaker, Dr. Jamina Rajabaksha, again, she is a very enthusiastic respiratory physician, and she is very technology driven because for the diagnosis, e-bus technology, she has learned a lot, and she is doing very well, and a lot of diagnostic input and getting specimens for Ramani Punjiheva and other pathologists. And she is attached to the Faculty of Medicine, University of Colombo, and mainly both are very academic oriented speakers. I would like to call one by one. First, Dr. Nurad Joseph to talk on lung cancer management, and then Dr. Jamna Rajabaksha. Oh, both of you. Firstly, Dr. Rajabaksha here. Over to you, Dr. Jamna Rajabaksha.
Thank you, sir, for that introduction. Good morning, everyone. So now both of us are going to talk about lung cancer management. I thought I will give an introduction as to what pathway we should follow when we arrive at a decision of which choice, this is about choices. So I will start at discussing like what are our choices based on. So our choices are mainly going to be based on the staging of lung cancer. Now Dr. Ramani Punjiheva gave a comprehensive review of how we are going to diagnose this once the specimen is received by her. But we need to think a bit before that, and to decide what sort of specimen we should get and how we are going to get that specimen, and what is the pathway basically for getting the specimen and sending it to the pathologist, and thereafter to the multidisciplinary team, and then to the oncologists or the surgeons. So the choices which are based on staging, the staging that we generally follow is a TNM based staging system, and it will give not only the diagnosis, but it will give the anatomical extent of the cancer. So it is going to be essential for the prognosis, selection or the choices of treatment, and how we are going to optimize this treatment, assessing response to that treatment, and also facilitating communications and research, which is important to build up on the knowledge we have. So the TNM classification which we are using now is based on the International Association for the Study of Lung Cancer Group Staging System 8th edition, which came out in 2016. So here I'll show you, this is the comprehensive slide, which is sorry, it's a bit busy, but this shows the entire thing in a nutshell. The next review or the next edition is due next year. So we will wait to see what differences there are in that. But for now, according to the 8th edition, they gave more than the previous editions, they made a lot of stress on the size of the tumor, which was the one which is the main difference with the 7th edition actually. So the size went very much from the staging differed from centimeter to centimeter, as it were, and also differed on the fact that whether there was endobronchial extension, local invasion of the tumor, and also whether there were separate tumor nodules. So for example, if we are taking the tumor size or the primary tumor on this side, the stages are given from T1 to T4, with T1 itself being divided into A, B and C categories. And the separate tumor nodules, whether they were going to be in the same lobe or in a different ipsilateral lobe, will upstage the cancer. If there was invasion into, or extension, into a bronchus, based on the distance from its carina. From the carina, it was given staging, and also whether there was local invasion to especially the pleura, and Madam also mentioned embolism into the lymphatics and the bloodstream. So this was about the primary tumor. When we went on to the N, or the nodal classification, that has not really changed from the previous edition. However, if this was the primary tumor, you need to know that the N1 stage is peribronchial, that means in the lung, and peribronchial, and also hilar, which is again within the lung. And thereafter, N2 staging went on to the mediastinum, which was ipsilateral peri to the main bronchus, as well as paratracheal and subcarinal. But the N3 stage became ipsilateral scalene nodes, as well as anything you could see contralaterally. So that has not changed, remains the same. Maybe there will be changes in the next edition. Distant metastasis, there was a little bit of change, but however, it has remained largely unchanged. Okay. So when we go from, so this is available, I mean, I'm not going to spend time on this. We have to move on to management, which is more important. So after you see your T, N and M staging numbers, we group them together and make a staging group. So for example, stage 1A3 would be this, whether there was the size of the tumor, no nodes, no metastasis, then you can go safely with the stage 1 cancer. But if you move on to stage 3B, that means it's a larger size tumor with maybe N2 nodes, and again no distant metastasis, and of course stage 4 is going to be a tumor with a metastasis. So there are finer points in this which you have to discuss when you meet with your team. Alright, so the lung cancer management main requirements before we go to refer to anyone is basically of two types. One is the sample acquisition, which is where we need the pathologist, and then to assess extent of spread, where we need a radiologist. So to acquire the samples, we need to acquire samples for diagnosis as well as to assess for targeted therapy. So both have to go hand in hand, and here I have shown the modalities for acquiring this particular sample. So you can either go for minimally invasive techniques or actual surgical or a bit more invasive techniques. So the minimally invasive, the easiest one, which is very much available everywhere, the two actually, are CT or whatever, image guided transthoracic biopsy techniques, and of course bronchoscopy. Then pleuroscopy is also rather widely available, and then finally endobronchial ultrasound as well, which is available in several centers here in the island. Surgical modalities are a bit more invasive. They require more theatre time and general anesthesia. However, in our countries, most of these are being performed very much, because sometimes the point is in all of these techniques, the sample you acquire is very small, like Dr. Puncheheva was telling. In surgical samples, they are rather large, and you can assess invasion and all of those things with surgical larger biopsies. So that is where the need arises there. When we go to assessing our extent of spread, the radiological studies are extremely important. The chest X-ray, of course, is a very primary requirement, but you need to do other CT scans, contrast enhanced scans, to see where else our cancer has spread. PET scans to see which nodes, for example, are involved, and of course MRIs where necessary. Especially even for surgical as well as for palliative intent, you have to do other testing to assess patients' fitness. For example, even if you are going for chemotherapy or radiation therapy, not only surgery, you need to assess other systems and see if your patient is fit enough, because owing to the late stage of diagnosis of our patients, they are generally very ill. So again, as one pathway, one main issue of assessing extent of spread, we do this mediastinal staging system, which is where this connection comes in. So we have to do some more diagnostic tests, some not diagnostic, staging system tests as well. These tests are employed at the same time. So it can be minimally invasive or again a surgical technique that we use. So some of the non-invasive mediastinal staging systems that I have mentioned, of course CT is a mainstay of our diagnosis, and then PET scans. These are actually films from one of our patients which showed these hot nodules and points in the mediastinum also, which revealed metastatic deposits in the mediastinum. So PET does perform better than CT at mediastinal staging. Then when you go to invasive mediastinal staging, of course transthoracic needle biopsy is a bit we don't do it much because of the danger of going through a large lung substance. However, it still is done in centers which do not have other facilities. We used to do, or we still actually do, conventional transbronchial needle aspirations, which is a blind sort of aspiration technique when we didn't have ultrasound techniques to go for. So you do follow the general lymph node positions and then do a kind of a blind biopsy which can go through the wall. This is a puncture which is seen in the wall, and you find your node and you go in there, find your node on CT. But there are dangers like bleeding if you go and hit a vessel on the way. So this was also going out of style once the endobronchial ultrasound methods came up, where you could actually visualize in real time and then go and acquire your sample while seeing it. So the very low risk of dangerous arterial or venous perforations. Then of course, to get a higher sensitivity, you can also use, so this is endobronchial ultrasound, this is endoscopic ultrasonography. So this is an endoscopic technique which goes through the esophagus and acquires samples from the mediastinum. Of course, you don't really need this scope because there is a procedure called EBUS-B, where where you put the EBUS scope into the esophagus and acquire samples as well. So it is, studies have found that when you do a normal EBUS along with an EUS-B procedure, it is as good a yield as a mediastinoscopy. So cervical mediastinoscopy, which is still largely done in Sri Lanka, is equivalent to having a EBUS and EUS-B procedure performed together. So this sort of makes us not require an EUS scope and a specialist GI surgeon to come and do the procedure for you, because the EUS scope is rather large and cumbersome, but the EBUS scope we are used to it. So you can do the EBUS and use the same scope in the esophagus and acquire samples. So that's for sample acquisition. So this shows the accuracy for staging of the mediastinum. As you can see, 89% sensitivity, 100% specificity, and positive predictive values and negative predictive, all very high, with EBUS TBNA in real time, and then the EUS as well as the EBUS together. It's obviously higher values there. So almost actually higher than the mediastinoscopy values, as you can see. So when we go to a management decision, now we've acquired our sample, we've sent it to the pathologist, and we know this, we know what do we do next? So earlier, those days, we used to just straight away refer to whoever we decided we wanted to refer to, but that is not the way to go. We have to form, we all have multidisciplinary teams in our hospitals, which consist of these specialists. We have the pulmonologist, thoracic surgeon, radiologists, pathologists, oncologists, and of course nursing staff, and later on we can involve social workers if we want. However, when you send a patient into your MDM, we need to send them at two levels. The first level, the basic requirement for an MDM would be, of course, your history examination, a referral letter from wherever they came, and primary imaging. So usually we would like a patient to come with a CT scan at least, or we do a CT scan once they come to us, and that is the first point of entry into the MDT, where the surgeons and the oncologists and the pathologists have a say in how we acquire the sample. That makes much less time for everybody in the process. The patient can move through the system very quick without us going and deciding which one to do. So if we do a early MDT, so to speak, and then everybody makes the decision as to which sample we should get. For example, the oncologist will say, okay, the radiologist maybe will say, this node looks positive, please go and do a sample on this node. And then the surgeon can say, of course, this is resectable, maybe we don't need to really go for a minimally invasive technique, why not do surgery straight away and take out the whole thing. We have done that for smaller nodules which look as if they have not spread. So that first entry without us going and doing our biopsy first and entering the patient is very important. Then of course post-procedural, the same patient can get the procedure done and then we enter them into the MDT secondarily to discuss on our final management. So these two MDM decisions are very important. Now this slide just shows which staff we generally have in our multidisciplinary teams and their roles. So thereafter, then we move on to the actual management decisions. We are armed with our diagnosis. We are armed with what sort of molecular problems this patient has, and we know the extent of spread of the patient's cancer. Then we are going to go on to management according to staging, and for this I will invite Dr. Nurad Joseph to continue.
Okay, thank you, Yamuna, for that very insightful introduction and your talk on diagnostic choices. Moving on to therapeutic choices. So basically it's stage 1 and 2. Basically you have an operable disease, and there's going to be a talk on surgical choices, so I'll just skip this bit. So basically if your patient is stage 1 or indeed certain stage 2 cases, medically not operable, certainly we can offer stereotactic body radiation therapy, which is a technique where we deliver higher doses of radiation in a shorter duration, so that cure rates are high, and it has been shown that it is superior to conventional radiotherapy. So it is a bit of a complex process. The delivery of radiotherapy is more complicated. You need modern equipment, but all of which we do have. Certainly at the Apeksha Hospital, we are able to deliver this treatment. And you can see this was the landmark Chisel trial where they showed that stereotactic radiotherapy is superior to conventional radiotherapy. If you want a review, this is a review we published on stereotactic body radiotherapy in the treatment of early lung cancer. So it's basically now standard of care. So what about SABR without pathology? Now we talked about surgeons going in and resecting lung nodules, small lung tumors without biopsy. So same can be done for SABR. If you think the patient is not fit for biopsy, or the process is going to drag on, maybe you've done a biopsy and it's inconclusive, it's okay to go ahead with SABR, provided your MDT has a high degree of confidence that it is a malignant non-small cell lung cancer. So if there is more than 95%, your MDT feels that the probability is more than 95%, then you can proceed with SABR without pathology. So it has its limitations. So you have this no-fly zone, about 1 to 2 centimeters from the carina. It's increasingly getting shorter. There are newer techniques, newer fractionation schedules are being tried out for central bronchial tumors. But basically you have a no-fly zone, because when you give very high doses of radiation to tumors centrally located, very close to the carina, you can have bronchial necrosis, and it can be worse than the disease itself. What about SABR in operable tumors? You're going to hear a talk on surgery later, but so
even if the patient is medically operable, you can still offer SABRE. Certain centers offering it. Of course, the trial. So any clinical trial which involves surgeons and oncologists, it has never been successful. Whether it is lung cancer or bladder cancer, the surgeons say their one is better, and we say ours is better. But so the trials have not been very successful. But certainly, it is increasingly being used. The Russell trial and the STARS trial, they were two landmark trials, but they had to close early because recruitment was poor. But when you do a sort of a pooled analysis, you can see here that SABRE is superior to surgery. I'm just saying, okay? So, right. So, you can, even if your patient certainly does not want to go for surgery, even if its surgery is fit, then certainly by all means offer SABRE. Moving on to more locally advanced settings. So the standard of care used to be chemoradiotherapy. If it's stage 3, maybe few selected T3N1s, maybe 3A selected cases could be managed with surgery. But the standard of care is chemoradiotherapy. However, we are now seeing increasing use of neoadjuvant strategies, sort of multimodality treatment in this category, because the outcomes with chemoradiotherapy in stage 3 isn't that great. So one strategy was to consolidate this with immunotherapy, because we know that lung cancer has a lot of mutations, and if you can somehow prime the immune system, you might be able to sort of consolidate the effects of radiotherapy. There was this study where we showed that lymphocytopenia post-treatment is a poor prognostic factor. So the Pacific trial, this was a trial of immunotherapy after chemoradiotherapy, showed that outcomes are better. So you give immunotherapy for 12 months after radiotherapy, and that improves outcomes. But more recently, we have this strategy of neoadjuvant chemotherapy with immunotherapy followed by surgery in sort of stage. So it's just a bit of a broad spectrum trial from 1B to 3A. But certainly the more locally advanced your tumor is, this strategy is quite effective. You can see there is an improvement in survival. And unlike in when you're giving immunotherapy sort of post chemoradiotherapy, you have to give it for 1 year, and that is very costly. So some of these trials are called checkmate, and so nivolumab trials are called checkmate because they checkmate the whole health system. You spend all your money on it, right? So, but with this neoadjuvant strategy, you only need to give 3 cycles of it. So 3 doses of immunotherapy with chemotherapy, and so it has about 25% complete pathological response rates, and survival is improved. So if you've got a locally advanced tumor, then this is a strategy that is emerging. You don't need to do PD-1 or PD-L1, but you need to exclude EGFR mutation. So because if you've got a EGFR mutation, then probably it's worth doing surgery and then adjuvant EGFR therapy. Moving on to stage 4, so it's incurable, and you're now moving on to symptom control, prolongation of survival. So you look for an oncogene sort of addicted tumor. If you have an oncogene which is positive, then you target that. If you've got immunotherapy targets, then you can use immunotherapy. Otherwise, you fall back on your traditional chemotherapy. So these are the options that we've got. It's and depending on so this is where your pathologist needs to provide us with lots of information. That said, you have this category of oligometastatic non-small cell lung cancer. That is, you have a lung cancer with 1 or 2 nodules. Again, you can go down the curative pathway. The surgeon can resect it. So, for example, this tumor, the neurosurgeon can resect the brain tumor, and you can either do surgery or radiotherapy for the lung primary. If you've got a solitary adrenal mets, we see this quite commonly. Again, you can resect it, and then you would go with curative intent. Even though sort of survival isn't that great, but you can achieve some degree of prolongation of survival. If you can't do surgery, you can certainly do stereotactic body radiotherapy. And this was a trial where they, for oligometastatic lung cancer, they went with SABRE, they sort of radiated every sort of spot that was there, and survival was better. If you can't do any of that, then you fall back on this slide. So this is a complicated slide. I just want to show you how complicated life is for oncologists, right? So this is squamous cell carcinomas. So molecular test negative, and then you go down various pathways. Yeah. So basically, if you've got a EGFR, if you've got a mutation, you treat that. Otherwise, you go with immunotherapy or chemotherapy. Then you come on to this category of oligoprogression. Again, something we see commonly. You find that your tumor is responding, but one or two spots are progressing. So you have, say, liver mets, lung mets, all regressing, but you find that some nodule somewhere is just increasing in size. So oligoprogression, and there. So technically, if you go by definitions, then that is progressive disease. You have to stop your whatever treatment you're giving and move on to second line. But that's doesn't make much sense. So again, you can use radiotherapy here. Just you select the lesion that is progressing and give stereotactic radiotherapy there. Again, that's a choice that you have to make. And then you carry on with your systemic treatment. With tyrosine kinase inhibitors, it has been found that when you do that, it actually resets the sensitivity of the tyrosine kinase inhibitor. Right. So I think so once we've done that and we've sort of exhausted all our options, we hand them back to the respiratory physician for palliative care. So I'm going to invite Yamuna to for the last part of our talk.
Thank you, Nurad. So now the patient has gone to the oncologist, received all that treatment, but depending obviously on the staging that we discussed earlier, can we move on to this part is very short. So the thing is, we may not decide to get the patient back into a multidisciplinary team to decide on palliation, and that is where our social workers and the nursing staff also have to play a big role, because they are in charge of patient triage ideally. And they will need to look into the assessment of informational needs, other psychosocial needs, and of course social needs. So if you can, after a period of treatment with the oncologist, get your patient back into the multidisciplinary, not everybody, but there may be a category of patients that you need to get in, then we will think of this concept of patient-centered care. Obviously, this is what we are going for. So we have to have follow-up visits with the oncologist as well as the pulmonologist, because not only the lung cancer which is being treated, we need to have a holistic approach to our patient and treat the lung problems which come again. Now, this patient, while being treated, will have other side effects of the lung cancer per se. They will have side effects of the treatment, and they will have side effects of maybe if they go for radiation therapy or surgery, they will have effects of that treatment also. Plus, in spite of all of this, the lung cancer will slowly be progressing, and they will have other effects of the cancer as well. So you will have to give them physical support, psychological support, as well as I mentioned, social support. So while we are going with this, what are the management choices after at this stage? So you can manage the patient's symptoms. You have to manage the symptoms, and there are some special problems that you need to manage in advanced lung cancer also. Now, this is a management tandem between the oncologist, the pulmonologist, and the thoracic surgeon. Hence the importance of the MDT again. I have to stress this importance continuously. So things like dyspnea, cough, hemoptysis, you manage as they come. how pain management, which we are having a lecture also, and things like constipation and such nutritional requirements need to be managed as well. If there is this special condition like malignant airway obstruction, for example, now you have done everything, you're treating, you've tried to downsize the tumor, surgical, but still you have malignant airway obstruction, and now we are palliating our patient. We can do this sort of procedure like endobronchial stenting and the coagulation techniques to minimize the size of the tumor and give the patient more lung volume to breathe with. So basically in the interest of making life comfortable for him. Then things like malignant pleural effusions need to be treated as well. Either you can get them down and do repeated aspirations, or now because we do have it here, we can do indwelling pleural catheter placement and get the patient involved in their own management. Pericardial effusions similar, and we don't have indwelling catheters, but then you can do aspirations. Then treat these other things also, which are special problems in advanced lung cancer. Then of course I think Nurad would have spoken of that as well later if we had a bit more time, about palliative radiation for things like superior vena cava obstruction, spinal cord compression and other metastases like he did mention here. So finally, in the interest of palliation, it's nice if we can have peer groups. We are trying to establish this. We have already done that in COPD in our clinics. If we can establish, that is the future for us, patient peer groups, it's better for illness understanding and coordination, and it's good for us to plan future decision making and to train our patients how to cope with illness. So yeah, this is one picture of a palliative lung cancer group, and it will make life better for all of us. So in summary, what we should remember is the entry points into our multidisciplinary team at the beginning before sample acquisition, so that, like we said, like Dr. Nurad actually mentioned, it's very important to now this radiation methods, surgical methods, and the proper sample which we need to acquire. That decision has to be made by everybody, not one person alone. And thereafter, once you get the sample, you come back, you get the patient back, not the patient, we discuss the patient again and decide where we go from there. Then after a period of treatment, it's nice if we can rediscuss our patient and see where the patient is now, especially in earlier, better stages like stage 1 and 2. It's good to have a follow-up plan in the multidisciplinary team as well. So, thank you.
Thank you very much, Dr. Yamuna and Dr. Nurad, for the two excellent and up-to-date talks on lung cancer management. I am sure it has gave us good insight and gave us valuable insight as to shed a lot of light to what has been going on this area. For our next talk, it's my pleasure to introduce Dr. Saman Iddagoda, an enthusiastic and young thoracic surgeon. We have Dr. Iddagoda is currently placed at the National Hospital of Sri Lanka and Lady Ridgeway Hospital for Children. And Dr. Iddagoda will talk on resectability versus operability, assessing the patient at the MDM. Over to you, Saman.
Thank you, Dr. Damit. So I'm going to discuss about, with regard to the lung cancer, what is meant by resectability and operability. So my previous presenters, I think they have given a good account on when a patient presenting with a lung lesion, and then how we are going to proceed with our management plan. So in a nutshell, so the multidisciplinary team meeting and then MDM discussion plays a major role in management of lung cancer. And again, when the management has been decided at the MDM, and then it is referred to the surgeon and to decide on surgical intervention. So I'm going to discuss in this topic with regard to the resectability and operability. These are my objectives. And so to start with, I think Dr. Ramani in her lecture clearly said, in Sri Lanka, in male population, it's the second most commonest cancer, which in the population as well as most of us, we don't appreciate that this is one of the most commonest cancer in males. And again, with regard to the female population, there's a rising trend in female
that there's a rising trend with regard to lung cancer presentation. And again, nowadays we are seeing some young patient presenting at later stage, in stage 4 disease, which we can't do anything, where the survival rates are very low. And with regard to these two terms, which we used at MDT level, where we discuss resectability and operability. So these are two terms, not synonymous, but we are using these two terms in combination in deciding in management. And in simple terms, resectability defines that there is no technical barrier for excision of the tumor, that is for the surgeons. And operability simply it defines considering various parameters where it identifies the surgical excision as the most appropriate modality of treatment for the patient. So if we move on, so with regard to resectability, mainly as Ramani madam said, so we had to think about the tumor diagnosis, histopathological diagnosis before we proceed into the management options. So that is the most important role played by the pathologist in the MDM discussion. And according to the TNM staging, what is the local, regional and nodal spread, and systemic staging should be done, and to have an idea about the resectability of the lesion. And there are a lot of surgical techniques which is available, and as you know, in diagnosed lung cancer, it is proven that anatomical lung resection is the best option in a patient that we can have like a surgical option. So starting with segmentectomies, lobectomies, and complete removal of the lung, which is called pneumonectomy. And there are like sleeve resections, which we remove part of the airway and do a primary anastomosis with the airway. So those are the surgical options. And the primary in resectability, we mainly decide as surgeons whether we can remove this lung tumor in an oncological manner, whether we can resect this tumor. So there are a lot of other things that we decide as surgeons in deciding resection. We have to know the microanatomy of the lung parenchyma, which is the pulmonary artery anatomy, pulmonary venous anatomy, and the bronchial anatomy. And sometimes as surgeons, we might not be able to do a lobectomy. Patient might end up in a pneumonectomy. So operability, it is mainly patient-related factors. So again, clinical pathological staging is the primary thing we have to consider before we think about operability. So operative risk in relation to the patient-related factors, age, other comorbidities, and performance status of the patient. Pulmonary functional reserve, especially the post-operative predictive FEV1 value that we expect how the patient will be tolerating after surgery once we remove the part of the lung. And cardiopulmonary functional status, and then I know that we had a good clinical session on pre-congress session on CPET, if you have participated for that. And patient wishes and social status also a factor when we are considering about the operability. So overall decision making at MDT considering resectability and operability, as I said, we can't take this thing in like separately when we are deciding at the MDM level. So resectability, operability, we take it as a whole when we are taking decisions. So in summary, patient-related factors, tumor-related factors, and surgery-related factors should be considered in deciding surgical treatment of the patients. So as I said, functional status, patient characteristics, operative risk, histology, stage at presentation, and especially for the surgeon, for ourselves, surgery-related factors, that is the type and complexity of the surgery and the surgical access and surgical method, and the skill of the surgeon and skill of the anesthetist also plays a major role in lung cancer management. So there are 4 scenarios that we see. So first one, as I mentioned here, there are medically operable and surgically resectable localized tumors. The primary management, we can offer surgery. And second one is medically inoperable and surgically resectable localized tumors. So in that case, the patient is not operable, so medically inoperable. So non-surgical treatment, maybe with the oncological team, we have to discuss, because surgery is high risk in these sort of patients, even though we can remove the tumor technically. And oncological treatment plays a major role. And medically operable but surgically unresectable tumors, that is locally advanced disease. So in these sort of tumors, we can offer these sort of patients with primary neoadjuvant oncological treatment. Then subsequently, we can do the resection after doing downstaging of the tumor. And the fourth one is medically inoperable and unresectable tumors. Obviously, there's no surgical option. As Dr. Nuraj said, either we have to go for a palliative treatment straight away or whatever. Even if you do a surgical option, that will be a option in palliative intent, as it like pleural disease in recurrent pleural effusions or any airway tumor in the airway, then we have to do like a palliative stenting. So just to move on with some clinical cases, this case 1, 73-year-old patient for hormone status 0, PT2N1 adenocarcinoma treated with previous VATS left upper lobectomy in 2019 and post-operative oncological treatment given. And the patient on follow-up, CT PET done, and it is reported that previous left upper lobectomy, there's loss of lung volume, and then there's a new 13 millimeter nodule with SUV7 in left lower lobe. So on the left side, there's only one lobe now. So there's a nodule, a 30 millimeter size nodule in the apical segment. And there's another small ground glass nodule in the right upper lobe. And there's no trace uptake on the right side. No mediastinal lymphadenopathy, background, paraseptal emphysema, hypertension, and CT needle biopsy cannot be done on the left lower lobe apical lesion. So what are we going to do now? So in this case, so there's a new lesion following surgery and then following oncological treatment. And so this lesion can be a new lesion, maybe a metastasis. So in the MDT, we have to discuss what are we going to do. So the options, are we going to do a left-sided, again, surgical option? Are we going to explore and then take the whole lower bout? Then that will be equivalent to a left-sided pneumonectomy, that is completion pneumonectomy. Or are we going inside from the left side and then going and taking the left apical segmentectomy and send for biopsy? And or are we straight away going for another oncological treatment modality, because already patient has been given post-operative treatment. So this is like a scenario I have just made with some details. So these are the cases that sometimes we encounter. So what are we going to do in this patient? Well, the CT needle biopsy is not possible, and the surgically, these sort of patients, if we can go ahead with the left-sided exploration and then apical segmentectomy, we can take it out. If it is a metastasis, then that's it. Or if it's again primary tumor, then we have to decide with the oncological team, can we go ahead with a further resection or completion pneumonectomy where the patient can tolerate the treatment, surgical treatment. Second case, 62-year-old patient, PS1, never smoker, right upper lobe persistent lesion, CT PET 3 centimeter mixed density lesion, right upper lobe with SUV 2.7. and no FDG avid nodule, previous mastectomy, background history, breast cancer with mastectomy in 2012, congestive cardiac failure, hypertension, CT needle biopsy, right apical lesion shows adenocarcinoma in situ, maximum size 3.4, T2A N naught M naught. So background, there's a history of heart failure and awaiting possible this cardiac resynchronization therapy device. And again, there's a past history of previous radiotherapy for breast cancer. So it's a complicated scenario. Again, like there's a past history of breast cancer, previous radiotherapy given, and there's a cardiac history and hypertension, congestive cardiac failure. So what do you think? Is this patient medically operable, or is this patient the lesion can be resected? So obviously, lesion can be resected because it's a 3 centimeter lesion. So it's not invading into the chest wall. And then there's no lymphadenopathy, so surgically resectable. But do you think this patient can undergo surgery? That is like medically, this patient is fit enough to undergo surgery. So what are the options? So can we go ahead and do a right-sided VATS upper lobe apical segmentectomy? Because you have to understand now, patient has had a previous mastectomy, and then already the radiotherapy has given chest wall radiotherapy. So part of the lung field might have been irradiated, and then patient might have like fibrosis. So sometimes you might not be able to go ahead with a lobectomy because patient's pulmonary reserve is not enough to breathe after surgery. So can you give radiotherapy again to this patient? Already radiotherapy given 2012, 10 years back. And what about the cardiology team's opinion? cardiac assessment, and then doing surgery. So in fact, this scenario, this patient is from, I have taken one of the patients that we discussed at Royal Papworth Hospital when I was working there. So I know in this patient, in Sri Lankan setup, I would not go ahead with the surgical, my opinion as thoracic surgeon, I will not go ahead with surgery. But there they have decided they will get the cardiac assessment and proceed with CRT device, and then proceed with right-sided upper lobe apical segmentectomy. And then decide with the oncological team what is the best option for depending on the diagnosis with the histopathology. So that was the decision that we have taken on this patient. The same thing might not be practical in Sri Lankan setup due to various reasons. So case 3, 60 years, right upper lobe lung adenocarcinoma with invasion into chest wall, involvement on endothoracic fascia between first and second ribs, stage as T3N1 M node disease on CT scan, current smoker, 60-pack years, performance status performance status 1.5, good spirometry with FEV1 1.09 and FVC 2 liters, and PET-CT brain imaging, no evidence of metastasis. So what are we going to do? So obviously the patient is medically fit for surgery according to the given history and then given information. Now for the surgeon. So it clearly says first and second rib invasion into the endothoracic fascia, and as a surgeon I will be concerned about this patient and I will clearly see the CT images. And because sometimes now it is invading into the first rib, second rib, which requires complete resection of the lung tumor along with chest wall resection. And these sort of patients, then definitely we have to discuss with the oncological team whether there's any place for oncological neoadjuvant treatment and then proceeding with surgery. Because the idea of doing surgery is to have an R node resection, which is a microscopic and macroscopic tumor removal. And sometimes these sort of patients, it's better to go ahead with the neoadjuvant treatment and then proceeding with surgery. And again, this is as it is mentioned here, first and second rib involvement. And we have to assess the subclavian vein, subclavian artery, and then lower trunk of the brachial plexus separately to decide on further surgical management, which is not mentioned here. But as a surgeon, I'm mainly concerned about that. So options, again, this patient, one of the patients that I encountered when I was at Royal Papworth Hospital. So what we decided was initially neoadjuvant chemotherapy, neoadjuvant treatment, oncological treatment, and then go ahead with surgical resection. So case 4, 67 years, performance status 0, ex-smoker, right upper lobe, non-small cell lung cancer, TTF1 negative, T2B and not M node, diagnosed with CT needle biopsy, and there's a CT PET with nodule in right upper lobe, 3 centimeter, and with a background of emphysema. So there's no other medical issues. So medically operable patient, surgically 3 centimeter lesion, no mediastinal adenopathy. Only problem is emphysema, surgical background emphysema is there, and we have to assess the lung functions and decide on what is the post-operative FEV1, and obviously we have to assess the functional status. We have to see the patient now. Here everything is directing towards the surgical option, but I would like to see this patient clinically in the clinic and see to assess how this patient's COPD status and whether the patient can withstand surgery. So considering about the now, those are like some 4 scenarios I have just wanted to show you to discuss about the resectability and operability and improving the care in local setup. So I can say that in Sri Lanka, the thoracic surgical service, even though there are only 4 thoracic practicing surgeons currently in Sri Lanka, we are giving the same surgical service which can be provided in UK setup. So we are doing the same surgical procedures, invasive surgical procedures, VATS, lobectomies, segmentectomies, airway surgery, and then stenting. And but nowadays with the economic back problem and all, sometimes there are a lot of issues with the equipments and the consumables. So sometimes we might not be able to do VATS lobectomy, even though it's a patient can be, we can do surgery on VATS lobectomy, but still we can't do it because of the consumables are not available. So what I would suggest is like there are like cancer breach timelines, so which is largely used in UK setup. When a patient comes to hospital for a cancer, and patient have like a breach timeline. In UK, what they take it as 4 to 6 weeks. So we have to give the treatment, whatever oncological treatment or surgical treatment should be done within 4 to 6 weeks minimum. So you can't breach the timeline. If you breach the timeline, there should be a proper reason, and then everybody in the team has to answer why we have breached the cancer timelines, and proper referral pathways, and implementing lung cancer registry. And I know there's a cancer registry with regard to the cancers, but what I am saying is with regard to surgical resection, and we have to have like what is the lung cancer resection rate in Sri Lankan setup. So I know, as Ramani madam has mentioned, most of the time, like if I'm correct, she has said a lot of cancers are presenting at later stages. So surgical option is not the option in most of the patients, so they are presenting very late. So if we can have like a lung cancer registry and see what is the resection rates in Sri Lanka, we might be able to implement a lot of things in improving our setup. And again, currently thoracic surgical service is giving only at National Hospital of Respiratory Diseases at Walliser, and then there are various logistic problems in improving the service in the country. And again, I would suggest like developing subdivisions in the field, like in respiratory field, there should be people whose special interest on respiratory cancers. And oncology, I think already there are people like having special interest on chest tumors. So that in that way we can have like improvement in our system. Okay, thank you very much.
Thank you, Dr. Saman, for that excellent presentation about surgical options. As you said, most of the cases are in late presentation. You may not be able to collect cases, and somehow our patients may even refuse surgery most of the time. They didn't want any scalpel in the chest and so on. So these are some obstacles for you, definitely. Anyway, we'll be having a discussion at the end. Now we are coming to the last part, that is about current understanding of pain and its management. So this is a holistic approach of treatment. We need the palliative care settings. In Maharagama also we have the ESMO recognized palliative care center as a consultative palliative care settings where the oncologists, anesthetists are all involved. I suggest even we are having visiting cardiologist and dermatologist coming to Maharagama. Similarly, if a chest physician also, because there are so many chest physicians here, one can visit 2 days per week. It will be good to do a lot of palliative procedures and all, and even some response assessment and all. Anyway, with that note, I would like to invite Dr. Victor Mendes from UK. He's a consultant in pain management and in the Hartswood Private Hospital in Brentwood, Essex, UK. Over to you, Dr. Victor Mendes, to do the presentation on current understanding of pain and its management.
Thank you very much for those very
You're online. Yes, you are welcome.
I'd like to take this opportunity to thank Dr. Ramini Karunatilaka and the Council of the College of Pulmonologists of Sri Lanka for extending this very kind invitation to present at your annual scientific sessions. I'm sorry I'm not able to be present in person, as I was only in Sri Lanka a few weeks ago attending the College of Anesthetic sessions, and it was impossible for me to get time off again, although I'd have loved to be back in Sri Lanka. I've been asked to talk a little bit about the current understanding of pain and its management, and it's a bit of a challenge to lecture to another specialty, but I thought I'll give you a bit of an overview and take you through the history of pain and bring you to what our current understanding of pain is. Ancient Greeks, Aristotle, for example, postulated that pain is due to evil spirits entering the body. Hippocrates suggested that pain is due to an imbalance in vital fluids of the body. But nevertheless, pain was not well understood and was believed to originate from outside the body, punishment from God. And in Buddhism, it is believed that pain and suffering is due to karma, and that pleasure and pain come from your own past actions. The first attempt to give a scientific understanding to pain was by René Descartes in the 16th century, when he proposed a link between peripheral sensation and the brain. He suggested that these sensations are directly conveyed to the brain, and that there is this passive neural relay of action potentials to the brain. And this explained the needs of the time, and only in the 20th century that Melzack and Wall, a physiologist and a great pain physician, challenged the notion of a hardwired system. They suggested that sensory information undergoes dynamic integration and modulation, and brought about the understanding of neuroplasticity. They said that the strength of the signal can be modified and it can be influenced by emotional and behavioral information. And of course, they suggested the gate or modulated theory of pain, which now, of course, has been outdated. The original classification of pain by the International Association for the Study of Pain is that it is an unpleasant sensory and an emotional experience, which is associated with actual or potential tissue damage or described in terms of such damage. There have been other attempts at updating the definition of pain, suggesting that pain is a distressing experience associated with actual or potential tissue damage, with sensory, emotional, cognitive, and social components. And this we see in managing day-to-day chronic pain patients as pain physicians. It's a very distressing experience. But is it the case? Is pain always a distressing experience? From the picture on the left-hand side, you can see this lady walking on fire with a spear across her cheek. The gentleman has piercings of metalwork across his chest. And the other two young gentlemen have all these spears and knives across their cheeks. None of them appear to be very distressed. How can this be explained? On the other hand, this is a patient I saw not too long ago with chronic low back and bilateral leg pain. The numerical rating score was 8/10, which implies that the patient was in quite a lot of pain. The MRI of the lumbar spine did not show any cause for the pain. The EMG nerve conduction studies were normal. How does one explain this? So let's look at a little bit about chronic persistent pain. The notion that persistent pain leads to changes in the brain, the peripheral and central nervous system, is of course now firmly established. And this led to the International Association for the Study of Pain appointing a task force, posing them the question, do we need a third mechanistic descriptor for chronic pain? Up until now, or up until this was suggested, we had two mechanistic descriptors, neuropathic pain, which is nerve pain, and nociceptive pain, which is inflammatory pain. The IASP task force recommendation for the third mechanistic descriptor of pain was adopted, and the new descriptor identified as nociplastic pain. Nociplastic pain is pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage, causing the activation of peripheral nociceptors. So the notion is that nociplastic pain is stimulus independent. You don't need inflammation, there's no need for any structural neural damage, and it is produced as a result of various mechanisms including central sensitization, peripheral sensitization. It is not a protective role, and it is a pathologic situation. The International Association for the Study of Pain, since the original definition, revised the definition of chronic pain in July 2020 and suggested and defined pain as an unpleasant sensory and an emotional experience which is associated with or resembling that associated with actual or potential tissue damage. The word resembling that was introduced into the current definition of chronic pain. Of course, they added 6 keynotes to further give context to the word pain. They suggested that pain is always a personal experience, that pain and nociception are different. You don't need nociception for the production of pain. Through life experiences, individuals learn the concept of pain. A person's report of an experience as pain should be respected. Pain is normally adaptive, but in the chronic state, it has adverse effects, and that the word verbal description is only one of several behaviors to express pain. And the inability to communicate does not negate the possibility that a human or a non-human experiences pain. And the result of all of this, the third mechanistic descriptor, the revised definition, led to chronic pain getting its own condition under the International Classification of Diseases 11. So the new system provides a single diagnostic code for chronic pain. And chronic pain now can be classified into chronic primary pain, which is pain that is in one or more region of the body, persists for longer than 3 months, is associated with significant emotional distress or functional disability, and cannot be explained by another chronic condition. Secondary pain is subdivided into post-surgical pain, cancer pain, neuropathic pain, headaches, visceral pain, and musculoskeletal pain. And the conditions that are included in chronic primary pain include fibromyalgia, irritable bowel syndrome, interstitial cystitis, chronic primary headaches, primary musculoskeletal pain, and chronic primary visceral pain. What are the mechanisms that are responsible for development of a chronic persistent pain state? There are various mechanisms, including peripheral sensitization, wind-up phenomenon, central sensitization, expansion of wide dynamic receptors, and of course, more recently, there's been a lot of attention on the importance of the descending pathways in chronic pain states. Central sensitization is one of the mechanisms. It is not new, but has been resisted by many healthcare professionals because we were taught well inside the box. Pain is a sign of harm, so pain is mainly in tissues. Something must be wrong or irritated inside your anatomy to feel pain. Yes, that is very important. But science has shown that much less dominant factor than anyone used to think. And countless studies have shown a surprising disconnect between symptoms and results of various investigations, including MRI scans. And this is a systemic literature review of imaging features of spinal degeneration in asymptomatic populations. There were about 3,000 people included in this systemic literature review where they undertook an MRI scan. The age groups were 20-year-olds, 30-year-olds, and 60-year-olds, 70, 80-year-olds. And what they found was that, for example, 50-year-old, 80% of asymptomatic 50-year-olds, their MRI shows disc degeneration. 60% of 50-year-olds, their MRI showed disc bulges in the absence of any symptoms. 36% of 50-year-olds had disc protrusions. And 14% of 50-year-olds who were asymptomatic had their MRIs revealed spondylolisthesis. You can see as you grow older, these changes become more pronounced. And of course, if you interpret these results or you start treating these incidental findings in a centrally sensitized person, you'll only make the pain worse. You'll sensitize them more and they become, they will develop a more chronic pain state. So one has to be very careful in assessing these patients, interpreting the results and identifying whether these patients with chronic pain have a centrally mediated component. There are various overlapping pain conditions within these centrally mediated pain conditions to include fibromyalgia, IBS, chronic fatigue syndrome, headaches, interstitial cystitis, endometriosis, low back pain, pelvic pain syndromes, and of course atypical chest pain, which is quite important for pulmonologists. The cardinal symptoms of any of these centrally mediated pain conditions include widespread pain, fatigue, non-restorative sleep, mood disorders, and memory problems. So there is altered nociceptive processing. This is a new dimension where the central nervous system can change, distort, or amplify pain, increasing its degree, duration, and spatial extent, and actually no longer reflects the specific qualities of a peripheral noxious stimulus. So in fact, there's uncoupling of the clear stimulus-response relationship that defines nociceptive pain. So we have moved from a very simplistic hardwired system that René Descartes proposed to a very complex, flexible, plastic system with ascending pathways and descending pathways that are influenced by prior experiences, anxiety, neurochemical and structural changes, sensitization, including peripheral and central. So therefore, when you are faced with a patient with pain, the assessment of pain is extremely important. You want to identify whether you're dealing with somebody with acute pain, is it chronic pain, is it acute or chronic pain, based on the original classification, is it nociceptive or neuropathic pain. But more recently, as I have explained earlier, we have this third mechanistic descriptor of nociplastic pain. So it's extremely important that we assess this and treat various types of pain accordingly. As pulmonologists, I don't suspect that you will see many patients with nociplastic pain. You may see atypical chest pains, but predominantly the population of patients that you will see will have acute, chronic, or neuropathic pain. So let's talk a little bit about how we manage these conditions, and I'll very briefly touch upon chronic pain. So assessment of a patient, getting a good history, discussing with the patient directly, establishing a cause, remembering that there could be more than one cause, assessing pain regularly. You can't assess pain once and then forget about it. You have to reassess. Is your treatment improving the pain, or is it getting worse? But assessing the influence of psychological, social, and spiritual factors, not only in the chronic state, but even in the acute state, is extremely important. So nociceptive pain, mechanical pain as it was previously sort of defined, is pain, inflammatory pain after injury, after surgery, after trauma, and it is sort of very acute pain, it is lancinating, it is very easily identifiable. What about neuropathic pain? Again, in the history, there are various pointers that might suggest that the pain is neuropathic. So the patient might say that they have electric type of shocks, it comes spontaneously. They have sensations of shooting sensations, burning sensations, etc. But there have been various tools that have been developed to identify neuropathic pain. These are validated tools. One is known as the pain detect. So the patient gets to fill this questionnaire. They ask about their pain in the last 24 to 48 hours. And then, of course, patients are also asked to describe the cause of their pain. And there are lots of specific questions here. And based on these questions, you get a total score. On the reverse side, based on the total score, if the patient, depending on the cause of pain, if the patient's pain is all sort of persistent, then you don't give any points. If the patient has pain attacks, then you give it -1. If the patient has peaks, then you give it +1. And if the patient has pain attacks with peaks, then you give it a +1. And then you add that score to the final score, and the screening result is based on this, where the score is on this chart. So you can have a score of between 0 and 35. If the patient scores something between 0 and 12, that's negative. That's not neuropathic pain. If it's more than 18, then it's definitely neuropathic pain. And if it's in this region of between 12 and 19, then it is unclear as to whether the patient has neuropathic pain. So assessment of pain is extremely important, particularly if you're dealing with somebody with neuropathic pain. But also remember that nociceptive pain and neuropathic pain coexist. For example, sciatica is a combination of nociceptive and neuropathic pain. Sometimes we forget this and we treat it as one entity. So management of acute pain, there are very good resources, and I would recommend this, which is freely available online. The 5th edition published by the Australian and New Zealand College of Anesthesia and Faculty of Pain Medicine, which gives a very good insight into the management of acute pain. They suggest that for acute pain you use the WHO ladder, but there are some recommendations to improve the WHO ladder for the management of acute pain, particularly using adjuvant agents in step 1. As I suggested earlier, nociceptive and neuropathic pain can coexist, and if patients don't respond to conventional analgesics, then early trial of adjuvant drugs, antineuropathic agents such as amitriptyline, gabapentin, pregabalin must be considered in that WHO ladder. They also recommend that include fixed dose combination of analgesics, and that clinicians should be trained to recognize that round-the-clock fixed dosing intervals and leapfrogging over step 2 is not only permitted but are recommended in certain specific situations, like in cancer pain, for example. And of course, they suggest adding a fourth step to manage very severe patients, where they suggest adding nerve blocks as a fourth step. These are the FDA-approved fixed-dose combinations, so one can use various combinations, including codeine with acetaminophen, dihydrocodeine with aspirin, etc. And as explained earlier, the fourth step, of course, is interventional treatments that also could be offered at a very early state. Management of neuropathic pain depends on whether the neuropathic pain is focal or generalized. For focal neuropathic pain, lidocaine plasters or Versatis plasters are recognized. That is a lidocaine plaster, and it was first studied in patients with post-herpetic neuralgia, but we use it very regularly for patients with scar pain. Very effective in all of these focal medications have no systemic effects. Capsaicin or the Cutenza, the active ingredient is capsaicin, which is an extract from chili pepper, and that is a capsaicin plaster that can be applied, can be used in painful diabetic neuropathy, post-herpetic neuralgia, scar pain, and certain types of acute neuropathic pain. These plasters can be used. Of course, if pain is more generalized, then you can't use these local or treatment options. Then, of course, you use systemic antineuropathic agents. NICE has come up with new guidelines and divides all neuropathy into trigeminal neuralgia and non-trigeminal neuralgia, but the drugs that are commonly used are amitriptyline, gabapentin, pregabalin, and duloxetine. We have to understand that pain is a continuum, and acute can become chronic if it persists or if acute pain is badly managed. So another important message here is that you have to manage acute pain aggressively in order for it to prevent it from becoming a chronic condition. We know that acute pain is clearly located, serves as a protective function, usually has an apparent noxious stimulus, resolves upon healing, whereas chronic pain has no protective function, degrades health, becomes a disease in its own right, and uncoupled from the causative event, and of course costs a lot of money. One of the important things to remember when acute pain becomes chronic is that the underlying mechanism, the processes that maintain pain change. So in the acute situation, the predominant processes are the inflammatory and the nerve injury. So it's peripheral processes. But as time goes on and pain becomes chronic, the central processes become the more predominant mechanisms. The plasticity, the receptor changes. And therefore, treating chronic pain is aiming at central processes, whereas treating acute pain is treating peripheral processes. And that is what can be seen in the acute pain algorithm, where there's a huge place for regional techniques, strong opioids, weak opioids, adjuvants, and not much of a place for the use of non-pharmacological techniques. Whereas in managing chronic pain, non-pharmacological techniques like psychological modalities, physiotherapy, rehabilitation, acceptance, commitment, all of these other things are very important. And then, of course, you add adjuvants and very rarely weak opioids. Strong opioids are not indicated in the management of chronic persistent pain. In fact, this has become a problem and has led to the opioid epidemic, particularly in the developed world. In the UK, we wasted 263 million pounds in 2017 wasted on drugs that don't work, which is relating to opioids. So in 2017, 10% of the opioid use in that year was spent effectively on chronic non-cancer pain, and another 10% was spent effectively on cancer pain and acute pain management. 80% of the opioid use in 2017 was wasted. I'm sure you're aware of the opioid epidemic, the harm that it causes, not only that causes opioid-induced hyperalgesia, but it causes immune, endocrine suppression, etc. So this led to the Faculty of Pain Medicine publishing a document suggesting that opioids are very good analgesics for acute pain, but that there's little evidence that they are helpful for long-term chronic pain management. Only a very small proportion of people may obtain good pain relief with opioids in the long term, but identifying them at the at initiation of opioids is very difficult, and therefore it is suggested that you don't go down that route, and that the risk of harm increases substantially over a oral morphine equivalent of 120 milligrams a day. And if the pain is not responding to any treatment and they are on opioids and it's not helping, you must stop the opioids even if nothing else is available. And that chronic pain is very complex, and if patients have refractory and disabling symptoms, then a detailed assessment of the many emotional influences must be taken into account. What about managing chronic pain? So the Faculty of Pain Medicine again came up with core standards for pain management services in the United Kingdom. Chronic pain management, of course, as I mentioned earlier, I'm not sure that a pulmonologist will be involved in management of many chronic pain patients, but the principles are that it has to be multimodal, multidisciplinary approach, and this document goes into details that there should be no single-handed practitioners providing pain management services, that these services must be accessible in all regions, we must undertake a comprehensive biopsychosocial assessment, including full needs evaluation, physical, mental health, and social circumstances, because all of these contribute to these patients' experience of chronic pain, and that pain management services should be led clinically by healthcare professionals who are trained to do this, and of course to offer various specialized services. So the message, of course, is when you deal with chronic pain patients, it's that getting the right patient to the right resource at the right place and at the right time. So in conclusion, when we treat chronic pain, we probably have to look at the brain and not the body, because as I explained, we have moved from a very hardwired system to a very complex system. So pain is a complex process that can be outside of awareness and control. Pain hurts where the brain thinks the problem is, not necessarily where the problem really is. Nociception is neither sufficient or necessary for pain. This I'm referring to chronic pain. And don't think and don't look for causes of pain in the chronic persistent pain situation. And neural networks that produce pain become more sensitive when pain persists, and this is the basis of neuroplasticity. So when we treat patients, it's important that both patients and clinicians view pain as a more complex phenomenon, not just as a purely sensory experience. Because if we look at it as a purely sensory experience, then the management is only limited to managing the sensation, and this is where we go wrong. And this is why managing chronic pain has become a challenge. So in conclusion, it is important to assess patients. Are you dealing with acute pain? Are you dealing with chronic pain? Is it nociceptive? Is it neuropathic? Is it nociplastic pain? And based on the mechanistic approach, one has to then treat these patients, and it is not always possible to extinguish patients with chronic persistent pain. Thank you very much for your attention.
Thank you very much, Dr. Victor Mendes, for that excellent talk on pain management. So we have now come to the last bit of this session, the Q&A session. And I hope Dr. Victor Mendes is also online with us for this session. So I would like to invite the audience to post any question for our speakers today, if you have, on the talks that they have given.
So my question is from Dr. Narudha Joseph regarding in the settings where there is no lung cancer MDTs available, the use of the performance status in deciding whether the patient should undergo a biopsy or not. What do you think in the era of when you have a targeted therapy is being increasingly available, whether can we use ECOG performance status in deciding which patient should undergo biopsy?
Yeah, that's a very good question. In terms of tyrosine kinase inhibitors, I think the European Society of Medical Oncology makes it very clear that it should be offered even to patients with poor performance status, because it's just a tablet, and if you've got the target, you can see a very dramatic responses. So I think we should certainly make every endeavor to look for these targetable mutations. But you're right in saying that there is obviously a category of patients, particularly in our setting, who we would not be offering anything more than supportive care. So in that setting, it doesn't make sense to go for biopsies. Yeah. And the ECOG scale is a very useful scale. We use it all the time in our clinical practice.
Any other questions? Yes.
Yes, Madam Ramani Punjikeva mentioned that 70 mentioned that 70% of the cancers are actually diagnosed at an advanced stage. But in my experience, it is even worse. Nearly 95% of the lung cancers are diagnosed at very late stage. I don't know whether there is any different people having different opinion. I think one of my opinion is that the reason why the cancer is diagnosed quite late is it is missed in the primary care. So our national program for tuberculosis control and chest diseases recommends any cough more than 2 weeks to be considered as a presumptive diagnosis of a tuberculosis, and those patients should undergo chest X-ray. So this is also useful in the diagnosis of a lung cancer. Though, however, in practice, less than 1% of the patients with the cough more than two weeks would undergo chest X-ray.
Yes, I can also answer. The problem is in Sri Lanka, mostly the late stage cancers we are detecting in that stage. Only issue is only the NATA or only one college can't fight for increasing the taxation of tobacco taxation. So I think College of Oncologists, College of Pulmonologists, and College of Cardiologists, and even this College of Community Physician all have to get together and lobby for increasing the taxation on tobacco, because tobacco industry is influencing a lot. Recently, you may know 2 cases came against tobacco companies for the pictorial warning in the tobacco packets, and that was very hardly. One government was a lot by the these tobacco companies. So I think we all have to fight and push the Ministry of Health as well as Ministry of Finance to go for more taxation on tobacco industries. So tobacco taxation should be increased. It's a single well proven method of decreasing the tobacco usage in a country. So we have to lobby and we have to get together and fight for that one thing. And also we may have to try to find the ways of early detection programs for the lung cancer, so that we may offer a lot to the cancer patients, because their survival can be increased and all. This should be done. And also some cancer patient also went to legally fought with the tobacco industry and got compensations. So few are going for that line. So we have to support them. That is one of my idea in this forum.
Yeah, I'm Dr. Handagala, one of the thoracic surgeons. Just to get an idea whether there is any sort of screening programs for lung cancer. I know in some developed countries there are at least targeted screening programs, because we detect a lot of early lung cancers in those who are going for the medicals abroad. Training, or so those who are going abroad, we detect patients who have very early stage lung cancer. If we can at least have some, targeted screening programs, maybe for smokers, maybe for those who are exposed to known carcinogenic agents, is there any place for screening? That would be a good tool to detect early cancers.
Yes, I think that's a very good question. Now, in countries like UK and US, they have this low-dose CT method that they use to screen smokers, especially smokers who are over 50 years, to detect early lung cancers. I hope Dr. Nurad can, or Dr. Yamuna can explain a bit.
Yeah, thank you, Dr. Handakala, for that question. No, the thing is, screening definitely is a necessity, and we are trying to implement, that's what we are doing currently, trying to implement a guideline, so to speak, to in order to choose the people who we can't be doing screening for everybody, yes, definitely. And like Adhavan also mentioned, if we at least had a chest x-ray for these people who presented with cough for more than a certain specified time period, then maybe we could, have a baseline investigation to go with. So what the College of Pulmonologists and the College of Oncologists have planned for the immediate future is that we are already on the way. We have formed a team to make a sort of registry, and we are collecting input on how, where patients present at which stage, and sort of then we can put in a proposal as to which patients or which category of patients require screening process, because we cannot screen everybody. And of course the level at like in the West, where they screen everybody over 55, is not going to be adequate here, because we do notice earlier presentations of cancer, especially in females and such, and who have been never smokers. So that is what we are in the process of gathering data right now, and we are making a database as we speak, so we can address that in the near future, hopefully.
Online also, Victor Mendes is there. Anybody wants to ask questions about pain management? I just want to ask about it. It's in Sri Lanka, we are just started to improve the palliative care services, especially in the cancer centers throughout the country. But still, we couldn't implement everywhere, so that they will have a better treatment, palliative care treatment. If you see they say the pain management is a surrogate, the better pain management is seen by a surrogate value of how per capita morphine usage and all. But in Southeast Asia, it's very in the bottom line, but Vienna and all, it's in well-developed countries, the per capita morphine use is very high. What do you think that because our morphine use and the morphine phobia among the practitioners, and the use of morphine, the 4-hourly, the timing, and all are not well sort of advised and so on. Our team is, we are not having enough resource people, and so how do you think about that morphine use differences across the world?
Thank you. Yes, I have been working across Southeast Asia, and I think Sri Lanka is much better than other countries like Bangladesh and Pakistan and India. But I agree that there's still a problem of opioid use in palliative care. This boils down to the fact that we haven't got proper organized pain services, which something Sri Lanka needs to really concentrate on. Not only pain services, but educating the population, but educating healthcare professionals about appropriate pain management. I know that there is a good pain sort of service in the cancer hospital in Maharagama, but this is only in one place. And I think it would be important to organize services across Sri Lanka. I know the College of Anesthesiologists has been trying to do this, but because of lack of manpower, they concentrate only on the anesthetic side of things, and the pain side gets quite isolated and ignored. But I think if the College of Oncologists and the College of Pulmonologists and all those who are also associated with dealing with chronic or cancer patients have some sort of association and try to link up with the College of Anesthesiologists in trying to improve this, that would be highly recommended. But I do agree that morphine and opioid use is not enough for palliative care in Sri Lanka.
Thank you. Since we are running behind schedule, I think we have to wind up this session now. On behalf of College of Pulmonologists, I thank all 5 speakers who gave some excellent talks on the areas today. Yeah.
Ladies and gentlemen, before we wind up today's session, there is now it's high time to felicitate all the dignitaries all the keynote speakers rather, who had come here to enlighten us with cutting-edge information on the field of oncology. So I'd kindly like to invite Dr. N. Jayakumaran to distribute the tokens of appreciation. First of all, can I have Dr. Ramani Punchiheva? Dr. Nurad Joseph. Dr. Yamuna Rajapaksa. This token of appreciation will be handed over to Dr. Yamuna Rajapaksa by Dr. N. Jayakumaran. And the next token of appreciation will be handed over by Dr. Damit Rodrigo. It will be handed over to Dr. Saman Idagoda. Also, the college likes to acknowledge the presence of our valuable chairpersons today amidst their busy schedules, and the college has arranged a small token of appreciation for their presence and their excellence here. Can I have some person representing the college to hand out the tokens of appreciation to Dr. N. Jayakumaran? And to Dr. Damit Rodrigo.